I'm Bill Hoffman, Communications, Department of Laboratory Medicine and Pathology, here with Dr. James McCarthy. Dr. McCarthy is Professor of Laboratory Medicine and Pathology, and he holds the Chairman's Fund Professorship in Cancer Research.
I grew up in Connecticut, near Hartford, Connecticut, in a town called Manchester, and spent the first 18 years of my life there. Spent a lot of time in Pennsylvania, which is where my family came from, and ultimately ended up in college in Pennsylvania. Susquehanna University, it's in the central part of the state, almost, north of Harrisburg. It's a liberal arts college, and I was there from 1970 to 1974. So it's a little bit of an interesting story. I was getting to the end of my college career and was interested in biology, was interested in research, really didn't know how to get started in it, and had a friend who worked at the National Institutes of Health. They had positions there for students, so you could have a part-time position at NIH, and you could be a graduate student or undergraduate student in the Washington area. So I went there and applied for a job, and also had to apply for graduate school. I went to graduate school at Catholic University in Washington, D.C., and continued to have my job at NIH in the National Institute of Dental Research, where I did my PhD research projects under the mentorship of Dr. Sharon Wall. I had another friend at NIH, his name is George Martin, who was a very good friend of Leo Furcht, and he recommended that I look Leo up and that I talk to him about doing a postdoctoral fellowship, which I did. I remember coming out here and meeting him, and was just really excited to have this next step in my career. And so that's how I got to come here. So during my postdoc, these are some of the questions that Leo was interested in. I really didn't have a clue in terms of what I would be looking at. When I did my PhD research, I studied inflammation, which is very important for gum disease, for advanced periodontal disease, and thought, well, basement membranes, they have nothing to do with inflammation. Well, they have everything to do with inflammation. They have everything to do with disease. So we got into this, studying cell adhesion, how do cells adhere to these structures, how do cells adhere to structures that are on the other side of a basement membrane, connective tissue, and our focus was in cancer cells, because the relationship between a cancer cell and those particular structures and tissues is abnormal, and they use those interactions in order to invade and ultimately metastasize. And so that's really been the focus of my research for the last, oh my gosh, I came in 1980, so you can do the math, several years. And our most recent projects are in ovarian cancer. And ovarian cancer has a lot of interest, and they all have a lot of interesting components that could be taken advantage of therapeutically. We're studying what we think are predictive biomarkers in ovarian cancer. And those biomarkers do many things in the tumor, including mediating resistance to therapy. So we're trying to understand how they do that, and also how they impact patient tumors. And we are collaborating with people in China who are looking at patients with ovarian cancer and tracking these biomarkers in their tumors to see what relationship they might have to the disease outcome. So we started with melanoma, and we started with melanoma back in the early 1980s because those were the cell lines that people had. Those were the tumors that they could grow in tissue culture, so we could take advantage of those cell lines and ask questions about how they do things, how do they adhere to these tissue proteins, and how do they process that information. And we made significant progress. We tried to identify what some of the mechanisms were that they used to adhere to these proteins, how they utilize that information, again, to invade and metastasize. And then we branched off into prostate cancer, which is obviously a different cancer, but shares many of the similarities. All these tumors share many similarities with each other, and also they have differences. But from our perspective, they share the similarities of altering their relationship to these structures, the basement membrane and connective tissue proteins, and they all utilize that information differently, ultimately to resist therapy, to invade and metastasize. So I've been very fortunate to end up in a pathology department. Pathologists, of course, I'm not one, but I do work with them. they are really the people to first view the disease at the tissue level. Surgical pathologists in particular get tissue sections, and they can look at those tissue sections and they can ask questions about what shape do those tumors have, how advanced are they, and they can make these judgments based on their experience looking at these. More recently, we've gone into the area of what they call molecular pathology. So a lot of these historical grading systems that have been used by pathologists to look at how advanced a tumor might be are now being replaced with molecular markers, and those molecular markers are the goal of having these broad-based molecular marker analyses is to come up with precision medicine, to be able to treat patients that have specific defects in the molecules that they're expressing and try to target those. So it's been a tremendous experience for me, and our department has been at the forefront of developing the technologies and the expertise that we can utilize to bring these new approaches into practice.